Hello to everyone. My name is María-Victoria Mateos, and I work as a hematologist at the University Hospital of Salamanca in Spain. And I would like to discuss with you the role of smoldering myeloma, diagnostic criteria, risk stratification, and what are the new options we have for the management of this population. You know that smoldering myeloma is a plasma cell disorder characterized by the presence of a monoclonal component of at least 3 grams per deciliter in serum and or plasma cell bone marrow infiltration between 10 and 59%. But what is important, there is not any myeloma-defining event. And these diagnostic criteria are crucial in order to do the differential diagnosis with monoclonal gammopathy of uncertain significance, as well as the differential diagnosis with multiple myeloma. What is the definition of myeloma-defining events? You know that this definition was updated in 2014, and myeloma-defining events means grave symptomatology, but together any one or more of the following biomarkers: clonal bone marrow plasma cell infiltration higher than 60%, free light chain ratio higher than 100, or more than 1 focal lesions on MRI. This means that this new definition for myeloma-defining events means that patients diagnosed with smoldering myeloma in the past should be now considered as multiple myeloma. But also, it's important to note that the recommended workup for the suspect of smoldering myeloma should include all assessments in order to exclude the presence of whatever myeloma-defining event. What is the risk of progression to active disease? Smoldering is a heterogeneous disease, and the risk is 10% per year during the first 5 years, 3% per year during the following 5 years, and 1% per year later on. This means that the risk is quite heterogeneous and the management is risk adapted. And this means that when we have in front of us a patient with smoldering myeloma, it is extremely important to evaluate the risk of progression to multiple myeloma. The International Myeloma Working Group endorsed a risk stratification based on the 2020 model. This means that we have to consider serum M spike 2 grams per deciliter, free light chain ratio 20, plasma cell bone marrow infiltration 20%, and high-risk smoldering myeloma patients would present 2 or 3 of these risk factors. This means serum spike higher than 2 grams, free light chain ratio higher than 20, plasma cell bone marrow infiltration higher than 20%. If 2 or 3 of these risk factors are present, the risk of progression at 2 years will be approximately 50%. In this International Myeloma Working Group risk stratification model, cytogenetic abnormalities were also added. Also, it's important to note that not all patients included in the analysis had the cytogenetic information, but the presence of 414, 1416, gain 1q, and or deletion 13q or monosomy 13q were incorporated in the model, and this means that together with the 2020 previously described, those patients presenting 2 risk factors will be allocated to the intermediate risk with 37% of progression risk at 2 years. But if the patient will present 3 or more of these risk factors, the risk of progression at 2 years will be approximately 60%. And it is possible also to predict the progression risk at 2 years throughout a risk score, including different levels for free light chain ratio and protein, plasma cell bone marrow infiltration, as well as the FISH abnormality. And based on this risk score, again, it will be possible to identify patients with intermediate risk or with a high risk. And for these 2 groups of patients, the risk of progression to multiple myeloma will be always higher than 50%. This model, I would say that it is going to be worldwide available, and from my point of view, this should be the starting point to identify high-risk smoldering myeloma. But it's true that it is possible to utilize other markers. The Spanish myeloma group analyzed the plasma cell compartment by flow cytometry, and we consider that if in the plasma cell bone marrow compartment, more than 95% of the plasma cells are abnormal, have an aberrant phenotype, together with the presence of immunoparesia. These two factors resulted in a median time to progression of 50% at 2 years, and this will be another model in order to identify the high-risk smoldering myeloma patients. But it's true that we can also consider PET-CT positive uptake in the PET without lytic lesions in the CT, or sometimes Ben-Jones proteinuria in 24 hours urine for smoldering myeloma with IgG or IgA phenotype, and all these models are also valid. It's true that we are in the process of incorporating new markers for the optimization of the risk stratification models, circulating tumor cells by flow cytometry in peripheral blood. When the level is at least 0.02%, the risk of progression to multiple myeloma is also significantly higher. And also it is possible to evaluate genomic profiling and the presence of mutations in the DNA repair pathway, MYC, MAP kinase mutations, or 414 translocation are associated with a higher risk of progression to multiple myeloma. And it would be possible, and the ideal situation would be to combine the models based on clinical markers with the incorporation of these genomic models. Also, sometimes physicians do prefer to evaluate the pattern of evolution of the monoclonal component together with other variables like the creatinine, hemoglobin, free light chain, and so on. And the final results are dynamic models. And the PANGEA model evaluated over 5,000 patients with smoldering myeloma, and it is possible to evaluate in a dynamic way the risk for progression, the risk of progression to multiple myeloma. And the group of Barcelona in Spain also evaluated the evolving pattern, evaluating the kinetic of the monoclonal component during 1 year in patients with high risk according to the 2-20-20 model, and this evolving pattern identified subgroup of patients with an ultra high risk of progression to multiple myeloma. So in conclusion, for the stratification of the smoldering myeloma patients, I think that today I would say that the 2-20-20 model is the starting point. The International Myeloma Working Group, together with the International Myeloma Society, are working in order to optimize the process for the stratification of smoldering myeloma patients, and it is planned to evaluate the incorporation of some genomic markers in order to precise more the identification of high-risk smoldering myeloma. But as I previously pointed out, the most important thing and the most important consideration why it is relevant to stratify smoldering myeloma patients according to the risk of progression to multiple myeloma is because the management is risk adapted, and low risk should be managed like MGUS patients. Intermediate risk smoldering myeloma should be followed closely than low risk, especially at the beginning, and high risk can be included in clinical trials, and why not, they can receive early treatment. The proof of concept we have in order to plan early treatment in high-risk smoldering myeloma is coming from 2 phase 3 clinical studies conducted some years ago in which Lendex or Lenalone were compared with observation in high-risk smoldering myeloma, and the benefit was observed in terms of both progression-free survival as well as overall survival in the Spanish group. It's true that these studies were conducted many years ago, and in spite of they didn't utilize the current definition of smoldering myeloma, for me it's important to focus on the control arm observation in order to see how the median time to progression in the Spanish study for the observation arm was 2.1 years, indicating that we were really dealing with a high-risk smoldering myeloma. And the same was applicable to the ECOG study, comparing lenalidomide with observation, and the benefit was basically observed in patients with high-risk smoldering, although benefit in overall survival has not been reported yet. But once these two clinical studies were conducted, there are other different approaches, some of them even based on curative approach, like the ASCENT study conducted by the International Myeloma Foundation, combining carfilzomib, lenalidomide, and dexamethasone plus daratumumab as induction, consolidation, and maintenance with the daralen. And the PFS is quite promising, although the follow-up is short enough. And the Spanish myeloma group conducted the Jim Cesar study also with curative intention, planning KRD, transplant KRD, and maintenance with lenalidomide. The primary endpoint was MRD negativity rate sustained 4 years after autologous stem cell transplantation, and approximately 1/3 of the patients met this objective. Time to progression to myeloma is quite encouraging, as well as overall survival, but we realized that the most relevant factor predicting progression to myeloma in this study was the achievement of minimal residual disease at the end of the treatment, at the end of the maintenance approach. Professor Landreg and his colleagues conducted a similar study with KRD, but without autologous stem cell transplantation, also with a curative intention, with similar results to those presented by the Spanish myeloma group. But what is important to note is in the era of the immunotherapy, we have the first phase 3 randomized study in which monoclonal antibody, in this case daratumumab, has been evaluated versus observation in smoldering myeloma patients. It's true that patients included were in principle high-risk smoldering, although if we consider that the 2020 should be considered the standard risk approach to identify high-risk smoldering, 37% and 43% of the patients in each arm were actually high-risk smoldering according to the 2020 classification. Overall, daratumumab resulted into a significant benefit in terms of progression-free survival versus active monitoring, with a hazard ratio of 0.49. However, if we look into the active monitoring arm, the median progression-free survival was 41.5 months, and this is longer than expected for high-risk smoldering myeloma. However, when we evaluate in detail the progression-free survival in those patients with high risk according to the 2020, the benefit is sustained. The hazard ratio for PFS is 0.36, and the median progression-free survival for the active monitoring arm was 22 months. So meaning that this model is valid for identifying smoldering myeloma patients in which the median progression-free survival is approximately 2 years. This study has also a trend to overall survival benefit with a hazard ratio of 0.52, and curves started already to separate. Safety profile is acceptable, and in principle, more infections occurred in the data versus the active monitoring arm as expected, but these infections were of short duration and the majority recovered or resolved. And in terms of other adverse events, there were not significant differences. So daratumumab as monotherapy will be maybe the first drug, in this case a monoclonal antibody, approved for the treatment of high-risk smoldering myeloma, and the ODAC meeting gave its positive opinion to FDA for the approval of DARA in high-risk smoldering myeloma, and the same for the CHMP for the European Medicines Agency. Other novel approaches are ongoing for smoldering myeloma with CAR T cells and bispecific monoclonal antibodies. But in summary, I would say that smoldering is a precursor plasma cell disorder. Its prevalence is higher than expected, 0.5% in people over 40 years. It is crucial to identify the risk of progression to multiple myeloma because the management is risk adapted, and high-risk smoldering myeloma patients benefit from early treatment. This had been previously demonstrated by several clinical studies, but today with daratumumab single agent in the registration Aquila study, we have maybe the first monoclonal antibody so far approved for the treatment of high-risk smoldering myeloma. Thank you very much for your attention.